Hi, everyone, and welcome to another fantastic Musical Innertube. I'm Don Rooney.
And I'm the almost as fantastic John Timpane. This week, we're revisiting our talk with medical reporter Cheryl Clark. We'll talk about the problems with Medicare Advantage plans. You know, the ones you're hearing about constantly this time of year and ad after ad.
Before we start listening again to our talk with Cheryl, let's remind you that Medicare has 4 parts, A, B, C, and D. There are other parts, but we won't get into those, and Medicare is run by the federal government.
Part A covers hospital care and major medical problems. There are deductibles and co-pays. Part B covers everyday things like doctor visits, medical equipment, and preventative care, but it doesn't cover things like dental and eye care. The government will take some money out of your Social Security benefit to pay for it.
Now, Part C is the Medicare Advantage Plan. It allows private insurance companies to provide things like dental and eye care, and it can provide extra benefits like groceries. You pay the insurance company for this directly, depending on the plan you choose.
And Part D is prescriptions. It's provided by private insurance, and the cost depends on what coverage you choose.
Now, instead of Medicare Advantage plans, you can purchase Medicare Supplemental or Medigap plans. They, too, cover some of the services not covered by Parts A and B and are purchased from an insurance company, but they don't have extras like grocery money.
Thoroughly confused? Great. Now let's get to talking with Cheryl Clark.
And keep listening at the end of the show for an update Cheryl has provided for us about where things stand right now in the wild world of Medicare Advantage plans. We're talking today with Cheryl Clark. Cheryl's been a medical and science journalist for more than 3 decades and is currently writing about Medicare Advantage plans, among other medical things, for the MedPage website. Cheryl, welcome to the Musical Innertube.
Well, thank you very much, Don and John. I'm happy to be here. Yes, I've been writing for MedPage Today now since 2015, and I really enjoy the latitude that they've given me to cover this topic, which not very many people understand very much.
Okay, you know what I'd like to do? I'd like to step back and do a Medicare 101 thing for just 5 minutes, because I think, a lot of listeners, even those who may have met Medicare, may not know about what gaps exist. So maybe this is the time to talk about parts A, B, C, and D and where the gaps exist. Now, you've mentioned that if you have only Medicare, you have to be responsible for 20% of certain costs in certain situations, and you have a deductible that you have to pay. So those come out of your wallet, right, unless there's other ways, unless you take out, basically a supplemental insurance program that will pay for those things. Am I correct?
Mm-hmm. That's right.
All right. And so we're talking about the different kinds of ways to fill that gap. I mean, Ed, what are some other things? I guess drug prices are another one that, even though they're sort of a donut because of the, that there's a donut in drug prices above which and below which people don't get paid for. But that's another gap, I think.
Yes.
In the coverage.
Yes. I think that gap was narrowed recently, I think, and also with the Inflation Reduction Act, they've authorized negotiations, so we have some good things coming with that. $35 a month insulin charges, which is really good. That's going to benefit a lot of people.
So if you're totally covered, you're going to have, different kinds of insurance that plug up the various gaps in the 4 parts of Medicare at the end of the day, right? If if you're smart, you do it all right.
Yeah. I think one of the overarching themes here is that Medicare is too damn complicated. It's too damn complicated for rocket scientists, and it's certainly too damn complicated for older people, especially who don't have the patience or the stamina to do this. I've been extremely critical of, recently in a story I did on my Part D plan where, part of it was my own experience where I went to the Medicare Plan Finder, was just supposed to be the gospel for every year during the annual re-enrollment period, you're supposed to be looking at the Medicare Plan Finder to see whether the terms in whatever plan you have changed. Now,
Yes.
do we have to do that? I mean, why in the hell don't we seniors have to take out time out of our day to go through the 46 plans that are available in our neck of the woods? We got the Part D. We got we've got dozens of available plans for Part D drug coverage. We've got a whole bunch of supplemental plans we can pick from. We got dozens of Medicare Advantage plan. It's too complicated. And within each of these three categories that I just mentioned, there are multiple layers. For instance, in my supplement plan, there's like A, B, C, D, E, F, N, G, that, you know, and so I just think the people in Washington and Baltimore have lost their minds. They don't understand who these people are that they're trying to serve. And I know that there are some people with MedPAC who agree with me, the Medicare Payment Advisory Commission. It's too complicated. When I got my formulary booklet in January after I switched plans to a better, more cost-efficient plan for me on the two generic statins that I'm supposed to take, the booklet said I had to pay $480 for one of these drugs, whereas the Medicare Plan Finder said it was only $118. So who was right? I called Cigna and to ask them, you know, which one is right, and two representatives told me that the $480 was correct. Well, it turned out that wasn't correct. It was actually $118, but it's too complicated.
Well, yeah, I think it's a given now that people, first of all, there are a lot more people on Medicare now because all the baby boomers are aging. So this becomes a big deal. And when the enrollment period comes through, which is, I think, the end of the year and lops over into January sometime, that's when you get just bombarded with these commercials. And they're still trickling out there from the different insurance companies, which begs the question, what is a Medicare Advantage plan and why do we need one?
Oh, good question. So Medicare Advantage plans are not exactly Medicare. They're supposed to cover the exact same things that Medicare covers, but they're actually run by private companies, which it gets a little complicated, but basically the Medicare Trust Fund pays these private companies a certain amount per month for every person that they enroll. And the amount is determined by how sick you are or how many pre-existing conditions you have, what sorts of care you have. And one of the big problems with Medicare Advantage plans that has been costing the Medicare Trust Fund billions and billions of dollars more than it should have had to pay is because the most of these companies, if not every single one of them, and certainly all of the big ones, have been upcodings. For example, they might say that I have arthritis, or they might, because I'm a 74-year-old woman, or they might say that I have prediabetes, but when the Office of Inspector General went back in to look at some of these upcodings, if you will, they found that there was no documentation. The beneficiaries, the enrollees, never got the care that they should have gotten if they had these conditions, and there was no support for any drugs that they would have been taken. So this has been a huge, huge issue with dozens and dozens of OIG reports on all of the major companies that run these Medicare Advantage plans.
Well, I think we should think about this because these commercials by now, especially if you have local television or cable TV, I mean, the numbers of these commercials and the famous people who are on them. In fact, I might add the famous old folks who are on them. They're everywhere now. They're part of our cultural stream. And I'm wondering, the question is, are there people who would benefit from these programs, and who are these people?
When I first became Medicare eligible many years ago, I actually thought, this is great because I'm not sick. I don't take any drugs. I can join one of these and all of this stuff would be covered, my gym membership, all that. But then I tried to get a routine colonoscopy. And it was like 6 months of a wait to get a routine colonoscopy. So I asked my doctor, Doc, why is it taking 6 months for me to get a routine colonoscopy? He said, well, you're in a Medicare Advantage plan. So if you don't really need a colonoscopy right away, if you don't have any issues going on, yeah, maybe a Medicare Advantage plan is good for you. But here's the thing about Medicare Advantage plans that nobody knows. I wrote a story back in 2019. It was called Medicare Advantage's Dirty Little Secret. Once you get in one of these, it's very hard to get out.
Huh.
So, here, let me explain. So, when you enroll in a Medicare Advantage plan, you can get out. If, let's say you don't like the network, you don't like the doctors, it's taking too long to get your goddamn colonoscopy. Excuse me, I can say that.
Yeah.
And you're getting frustrated and you want out. Within the first 12 months, you have guaranteed issue. You can get out and you can buy a supplemental plan and have your 20% of your Medicare Part B and your deductibles all covered. But after that first year, you will, unless you live in Pennsylvania, New York, Maine, or Massachusetts, which prohibit medical underwriting, supplemental plans can say no. You have prediabetes, you have low vitamin D, you have arthritis, you were in the hospital last year. We're not going to accept you. And so then, why I say it's almost impossible to get out of one of these Medicare Advantage plans, if you tried to get out and just get traditional Medicare, you would incur 20% of all of your doctor's visits, your labs, your imaging, $1,600 for every time you were in the hospital. It would become very, very expensive and it would possibly bankrupt you. And this is the thing I know for a fact, a lot of brokers who, these ads that you're talking about direct you to these brokers. They don't mention this. They're not required to mention this to you. The other big issue that is inherent with these ads is that the commissions, and by the way, the Centers for Medicare and Medicaid Services sets the commissions that brokers get for selling you a Medicare Advantage plan, and they're a lot higher than if they sold you a supplemental plan. So there's a lot of incentive for these brokers to direct you. Yes, they may be licensed to sell health insurance, but there are no requirements for them to tell you all of the downsides.
Wow.
It's interesting, too, because it seems like there's layers here. There's the people who need health care. There is Medicare. And then there is the Medicare Advantage, most of which seem to be run by existing insurance companies. And then there's a broker that sells that Medicare Advantage plan from that insurance company to the person that needs it. So there's all sorts of layers here. And where there's layers, there's lots of money. And where there's money, there's cutting corners or there's usually shenanigans. Can we put it that way?
There's really good news about these ads that you mentioned, though.
They're going away.
The Centers for Medicare and Medicaid Services, several of the stories that I wrote, are really cracking down on these third-party marketing organizations, which are the ones that you're led to from these TV ads. They're going to require that the ad say which plan will give you money back on your Social Security check, like you mentioned, because I think I saw the percentage only 2% of the plans actually do this. And it's only in certain parts of the country.
They tell you, give us your zip code and we'll tell you whether or not you get money back. So what does the zip code have to do with it? And frankly, where's that money coming from? I mean, what money are you getting back?
Well, supposedly that money that you are that's withheld from your Social Security check for Part B, there would be a discount for that you would get back. But I read in one of the regulations that this only happens to just like single digit percentage of the time in the plans that are sold. It's very, very small. Most of the plans will take the full amount of Part B that they can. And the other part is that, Part B also has IRMA with it, which is for higher income. So if you have a higher income, you're going to get the IRMA and you're not going to get a discount. So
interesting. The more that you make, the less of that you can enjoy. I understand that. When would I decide to get a plan like this as opposed to a supplement? Because I think most people who are in Medicare years know that there's a gap that you have to make up somehow in your healthcare insurance, that Medicare doesn't cover everything a lot of the time. So between this and another kind of supplement plan, who are the people who would benefit from getting the plans we're talking about here?
Well, in my view, people who get a Medicare Advantage plan make a decision to save money now instead of saving money later.
Mm-hmm.
Most of the people that I know who bought a Medicare Advantage plan end up getting some sort of a condition where they have to go see the doctor. They are in the hospital. Those Medicare Advantage plans, a lot of them, $500 per day hospitalization charge. The amount of the cost sharing on the prescription drugs, it's not total coverage. There's going to be dollars and cents to that, and lots of dollars and lots of cents. So, my view is that for $100 or $150, I pay $245 a month for the most expensive supplemental plan that I can get. And last year I fell off a motor scooter and I had to have wrist surgery, and I had to have eye surgery too because I had a little wound in my eye from the accident. And I saw what I would have paid if I had been on a Medicare Advantage plan, and it was almost $10,000, whereas I only paid $240 for my supplemental plan, and I paid nothing. On those charges. So my view is that if everybody knows that they can't automatically jump out of a Medicare Advantage plan and get into a traditional Medicare with a supplement, they would think twice about spending a little extra money and getting that supplement plan. I just don't feel that the entire number of downsides and the severity of these downsides are adequately explained to beneficiaries when they're enrolling. Now, a lot of my friends, my generation, reporters, smart people, editors, photographers that I worked with over the years, they bought these Medicare Advantage plans, and now they're having a devil of a time trying to get a particular series of symptoms diagnosed. The delays and the prior authorization denials that they encounter. One of the recent stories I wrote about, should doctors ethically talk to their patients about the downsides of Medicare Advantage plans? And we at MedPage Today, we write for doctors, and we hear them complaining all the time about these prior authorization delays and how much staff time it takes to reapply and re-explain. Why does this patient need this test? And so the idea is that doctors should really talk to their patients. It's going to take me 3 weeks to get this procedure authorized, and we're talking about a potential metastasis and trying to scope out, where your cancer is right now to determine whether we should do chemotherapy or surgery. I'll tell you, I, for one, don't want to have to wait 3 weeks. That was the example that I gave in one of my stories, I believe the October 13th one, where we interviewed a man who had just turned 65 who was being worked up for pancreatic cancer. He was in a Cleveland Clinic facility in Florida, and his oncologist came up to his room to tell him that she didn't really know whether she would want to do chemotherapy or surgery first, because they needed to get a PET scan to really understand what they were working with. And she said, unfortunately, I can't really get you that test for another 3 to 4 weeks. And the patient sat there and said, well, why is that? Why can't you get me that test? This is the Cleveland Clinic, for God's sake. And she said, well, but we've got prior authorizations. We're going to submit it. It's going to get denied. We're going to submit it. It's going to get denied. And we'll finally submit it, and they'll finally approve it. And you'll get the test, but it's just going to take a while. He said, wait a minute. I don't think you understand. I don't have Medicare Advantage. I have traditional Medicare and a really healthy supplemental. She said, oh, well, that's different. Why didn't you tell me?
Why didn't you say that before?
We'll get to the test in 3 days. So those are the kinds of issues that your one doctor that I interviewed, who also happens to be a good friend of mine, he said, just explain it this way. You're trading money for access.
When somebody's looking then for something like this, when they go outside of the Medicare bubble, they're looking for a Medicare supplemental plan and not a Medicare Advantage plan. That's a good way to go with that?
You can do it 3 ways. You can do Medicare alone and cough up that 20% and that $1,600. You can do a Medicare Advantage plan, or you can do the Medicare and a supplemental plan. Medicare does not offer supplemental plans. You have to go to the same company, some of the same companies. Yeah, they're also private companies, but they're obligated to pay that 20% or your $1,600 hospitalization deductible for every time you have a hospitalization episode. They're obligated to pay that if it's an approved Medicare charge. I have Blue Shield of California, which they pay for everything and then some. They also pay for hearing and hearing and vision and a whole bunch of other sorts of things that Medicare Advantage plans pay. And I pay a little bit more for that privilege, but they're private companies. You also have to buy a Part D plan if you have Medicare. Well, you don't have to, but you kind of have to, because Medicare will fine you if you delay. And
yep, right, exactly. They will if that's the only insurance you have. Yes.
Yeah, and I didn't know that, and I have to pay $1 every month more for my Part D plan.
Oh, look at you! It's awful. Oh my God, how will you do?
Okay, because that covers a lot of ground that I was going to ask about, and that is the big pitch of the Medicare Advantage plans is that they give you dental, they give you vision, and they give you hearing aids and that kind of stuff. But you could still get that. Can you still get that through a supplemental if you go there?
Some of them do. My Blue Shield of California plan is an F, which is the high-end plan. It does offer some of these other things that I believe I can see a chiropractor if I want. There's some other things that Medicare may not ordinarily cover.
So you personally, now everybody's different. We all have different needs, and respecting that and not wanting to invade your privacy a lot, but you have Medicare. You also have just not an Advantage plan, but a supplement.
Mm-hmm.
All right. Do you also have a drug cost supplement plan?
I have a drug plan, yes. And I went on the Medicare Plan Finder and typed in the drugs that I am prescribed and the 2 statins, and Plan Finder produced an algorithm that showed the best drug plan for me. Now, if I had stayed in my old plan, I would have been paying $44.50 a month. Under my new plan, I'm paying $12 a month. My old plan was going to cost me something like $200 for one of the drugs and about $90 for the other. The new plan, one is $0 and the other one is $118. So I saved some money, not much.
And I think that a lot of people like feeling as though they can be an informed shopper in this marketplace, because as you say, it's the ultimate in intimidating marketplaces. There's just so much you need to know, and a lot of hidden sort of IEDs, on the road.
We'll return to the Musical Innertube in a moment, but first, here's a soothing musical interlude.
Cheryl Clark has been a medical and science journalist for more than 3 decades. She is a 4-time finalist and 1-time winner in the National Institute for Healthcare Management's Journalism Awards program.
Cheryl was one of the nation's first reporters to cover HIV/AIDS at a major newspaper in the early 1980s. She covered the rollout of the Affordable Care Act between 2009 and 2015, and she authored a 2018 series on a diabetes treatment that experts called a scam. Her reporting became a PBS NewsHour segment with Judy Woodruff.
Check our webpage for a link where you can read Cheryl's articles for MedPage, and you can email Cheryl herself at c.clark@medpagetoday.com.
And now, we return you to the aforementioned Musical Innertube, already in progress. We've heard this out of the people in Washington over and over again. You know, the private sector can do it so much better than the government. And that seems to be what we are now, is that the government has Medicare, and that's okay if you're hospitalized. But beyond that, we should leave it up to the individual insurance companies. And we all know how efficient and wonderful they are. And that may be some of what's adding to this layers. Because the thing that clicks in my head as you're talking about the pre-existing conditions and the waivers that need to be gotten and the referrals and that kind of thing. This reminds me of back in the 80s when HMOs were supposed to be the be-all and end-all, and they just wound up screwing people royally, I think.
Yeah. Yeah. You know, I make a point about that because when Part C, which is Medicare Advantage, was first introduced by the Bush administration, I remember sitting in the editorial board offices of my newspaper just thinking this was so great because remember there was so much overutilization and doctors were being paid per click. The more they did, the more they got, more money they got made. And it didn't really matter that the guy down the street had just done the same test. He was going to do your test all over again because the other guy probably didn't do it right. So the whole idea of managed care, Medicare Advantage Plan, is a really good one. So because you've got a small group of doctors in a network and they know you and they're all reading each other's notes and they're not doing the same test twice. So the concept of this is wonderful. It's just that greed and this upcoding scandal, which is ruining the Medicare Trust Fund. It's gouging. I know people are wondering how we're going to pay for Medicare. Well, here's a place. Billions of dollars of the Medicare Trust Fund are now going to these private companies to provide care that they are not giving their beneficiaries, or they're delaying and delaying and delaying until, hey, the patient doesn't need that test anymore because they're longer.
They're out of here.
Yeah.
Yeah. I mean, it's a part of this, and Don brings up an excellent point, is that Medicare is a compromise. The wise heads in Washington came up with a plan that is partly socialized medicine. It certainly is. And then partly these gaps, which were constructed so that we would have to hire people from the private sector basically to make up the gaps. I mean, it shows this is what a camel designed by committee looks like, that this embodies really the political reality of the United States. I mean, we don't want to think that we rely on government totally. It doesn't seem to really, worry Canadians. It doesn't worry many people in Europe or elsewhere who they may have to wait for tests sometimes. Sure, they do. And it's not perfect. But in our system, we've always had this sort of this unwritten rule that, we don't want it to look too much like socialism. It
seems to me that the federal government just doesn't want to be in the business of providing health care. One of the reasons why it created this Part C business during a Republican administration. I know that everybody in CMS is worried about this. There are a bunch of proposed rules that CMS has put out in the last couple of weeks and months that would really tamp down this misleading, deceptive, dishonest advertising, and they actually use the word misleading.
Can you remind us what CMS is?
Centers for Medicare and Medicaid Services.
That's great. And is that a private roundtable that issues suggestions every year. Can you tell us a little bit more about it?
Enormous federal agency in Baltimore and Washington that sets rules for what is going to be covered by Medicare, what sorts of quality benchmarks providers have to. They produce the huge amounts of data about doctors' claims and hospital claims, and they run Hospital Compare, Hospice Compare, every kind of, and I think soon to come is ambulatory surgical quality of care. So you can look up on federal websites and see, rates of readmissions, hospitals that, it's a very important federal agency with, I can't remember how many employees. I remember, tens of thousands of employees.
I think the other point that you've made that I think is really interesting is that we have to remember that these programs, like most large public programs, are always being tinkered with, and for good reason. I mean, there's economic reasons why they have to be tinkered with. The change in the value of the dollar often means change in the value of healthcare, and so there will be yearly changes to almost all of them. But finding out what the changes are is hard. I mean, I guess you do get that little letter every year if you're a Medicare person saying, or you get, the flyer from AARP. Here's what's changed in Social Security. Here's what's changed in Medicare. But those are the big headlines. They're not, as you've said, there can be changes that are not well known that come back to haunt you.
We shouldn't have to pick a different plan every year because there's so many moving parts. I think one person described it to me as a Rube Goldberg machine.
Yeah.
So many moving parts to, I think there is an effort federally to try to simplify this and say, here's an apple plan or an orange plan or a pineapple plan. And pretty much all the plans in the pineapple category will give you these benefits, and not have this so all over the map with moving parts with deductibles, moving parts with co-payments, moving parts with co-insurance, all these different premiums. That's another moving part. What is your premium? You go in the Medicare Plan Finder and you look, well, what's the cheapest plan for me? And you look only for premium. Well, that's not going to do it for you because the costs for various services may be a lot more than that low premium you picked out. So it's too complicated.
One other thing that we have to bring up, and it was a recent article that you put for the website, and that is that, again, in adding extra layers to this and adding extra greed, I suppose, when patients go on their portals to look for advice, messages from their doctors, lab results or whatever, they're now getting advertisements for the Medicare Advantage plans. And these, to some people, kind of suggest that maybe your doctor is endorsing this, which is farther from the truth, right?
I'm so glad you brought up that last story I did, because this just outraged so many people. It turned out that this gentleman who emailed me from North Carolina, he told me his doctors didn't know anything about this. And indeed, the PR person for his health network in western rural North Carolina did not know that they were doing this either. And I am still stymied in my efforts to try to figure out how they got around doing this, because the message that he got in his portal said, if you click on this personal code, your drugs, all your drugs and your doctors will go to our partner, who is an insurance agent, who's going to sell a Medicare Advantage plan. And I think the naive, innocent user of this portal would click on that thinking my doctor wanted me to do this. I don't know why this didn't violate HIPAA. The Health Insurance Portability and Accountability Act, which, when I go into my portal, I want that stuff I don't want everybody to know, how many milligrams my doctor wants me to take of that statin, how high my cholesterol is, or, so I think that's a big concern. And I haven't been able, my talents as a inquisitive journalist have fallen short of actually getting the answer to that. So I'm hoping to do more work on that.
I'm absolutely outraged. I didn't know that. That shows you I haven't been on my portal in a long time. But and this is the way that the web works too, because there's a lot of places to click. There's a lot of offers, and this is playing sort of a shell game on what should be a government website. Why that is. I want to cry.
Yeah, it's supposed to be regulated, or I would think it would be regulated by Health and Human Services Office of Civil Rights, which oversees HIPAA compliance. But apparently there is a loophole that some of these platforms, these portals, that in this case it was Follow My Health, are able to use some sort of a loophole involving a business associate agreement with the health system that allows them to send users advertisements like this. If they say, yes, I want my message, that somewhere there's apparently a default which says, yes, I want all my messages. And so they feel that's an entitlement to send you this sort of nonsense. No, this is my private portal.
It's your private portal. People should not be allowed to sell things to you. It should be information only.
Yeah.
We have another layer situation now where the doctor has set up a portal, but the doctor's office doesn't run that portal. They field that out to somebody else, some other company that runs the portal. And that company says, well, we're going to sell you ads as a way of making money off that portal. And so your doctor probably doesn't even know that the portal has ads running on it.
That was the case here, with the North Carolina issue. I have just got a message from the Center for Medicare Advocacy, which is a big organization of attorneys who advocate for Medicare beneficiaries. And the one of their staff people received the exact same message from the same portal, Follow My Health. So I don't understand the arrangement. You're right. The doctor didn't know about it. The health plan, which is called the MAHEC, Mountain Area Health Education Center, their representatives told me that they didn't know about this and they regretted it. They weren't endorsing this. I guess they thought that all of their users were going to be smart enough to figure out the difference between a message from their doctor and a bald ad for a Medicare Advantage plan. But I just worry that a lot of people might not, when you forget things, you don't know, maybe you're not that used to using computers. I don't know.
Like I said, the baby boom generation is now moving into the Medicare generation. Thousands of millions of people are now having to deal with this. They're entering portals. They're signing up for Medicare and maybe for Advantage plans. What is a logical person to do in order to cut through all this crap and find out exactly what he or she needs to do that's to their best interest?
Oh, that's a wonderful question, and I have an answer. I actually have an answer. Every part of the country has a SHIP program, SHIP, State Health Insurance Program, and it's federally funded, not enough, in my opinion, to hire trained, reliable counselors. You can call them up and you can talk to them about, what your issues are, and they can help guide you and explain a lot of these downsides of these Medicare Advantage plans and some of the upsides too. You may live in an area which is covered by, a Medicare Advantage plan, but the kinds of services you need are not in that network. You may have a particular kind of cancer, or you might need a particular kind of surgery, and it's just not nowhere near you. So these SHIP counselors, they're in every state. I found them to be absolutely marvelous as sources for my news stories. And they've given me a lot of tips on things that were happening out there, and that I just feel that they should be receiving a lot more money to hire a lot more counselors, because, as you said, it's like, 65 million Medicare beneficiaries now, with 10,000 more every day coming of age eligibility. I think that is one really I would not rely exclusively on what a broker told me.
Right. So this is called the State Health Insurance Program, and it's in every state. And you can call and actually get somebody to answer your questions.
Yes. Now, in a few states like California, we call it HICAP, which is Health Insurance Counselor Assistance Program. I think it's called HICAP. New York has HICAP. A few other places call them HICAP, but it's the same. It's the SHIP program.
And now here's an update. Cheryl has provided us with some stats and some figures about how changes are occurring in the Medicare Advantage plans since we had our talk with her earlier this year.
You know those ads that tell you to call an 800 number to check and see if there have been changes to your plan? Well, the call actually connects you with an insurance broker. As you might expect, these brokers make money by selling you a plan.
Now, this month, the Centers for Medicare and Medicaid Services, or CMS, proposed a rule that would limit the total that these brokers would make on any sale to $632.
That's because right now the brokers are allowed to accept quote-unquote incentive fees from insurance companies as high as $1,300, along with golf parties and vacation trips.
Back in April, the CMS required those TV ads for Medicare Advantage plans to be reviewed by the agency before they appeared on TV to make sure that there's nothing misleading. You'll notice that this year's ads aren't talking as much about getting money back on your Social Security card because, as we found out in our talk with Cheryl, that hardly ever happens.
You can find out about other changes proposed by the CMS by checking out Cheryl's MedPage articles. Just go to our website, musicalinnertube.com, where we have a link to Cheryl's stories.